Lyme disease is a bacterial infection that is spread to humans by infected ticks. Lyme disease is not contagious. Although Lyme disease is not a common infection, we do see a higher number of cases in the west of Ireland due to the large national park in Connemara. The ticks that cause Lyme disease are commonly found in woodland and park areas. This is because these types of habitats have a high number of tick-carrying animals such as deer, mice and sheep. Due to their breeding patterns, the tick population is highest in late spring and early summer. If a tick bites an animal that has the bacteria, they can also become infected with it. The tick can then transfer the bacteria to a human by biting them and feeding on their blood. In general, the longer the tick has been attached to the skin, the greater the risk of passing on the infection. It is uncommon for the infection to be passed in the first hours after a bite, which is why it is so important to look for ticks and to remove them. The problem is that the ticks are very small and they do not cause pain, so it can be difficult to realise that you have a tick attached to your skin. The most common symptom of early stage Lyme disease is the appearance of a distinctive skin rash that is known as erythema migrans. This is also referred to as a target lesion. This rash looks like a bullseye in the centre of a dartboard and develops at the site of the tick bite. The skin affected by the rash will look red and feel slightly raised to the touch. The size of the rash can range from small to large. Other symptoms of early stage Lyme disease may include the following: fatigue or tiredness, muscle pain, joint pain, headache, fever, chills, and sometimes neck stiffness. Risk factors for Lyme disease include any activity or occupation that involves prolonged exposure to woodland and park areas like hiking, camping, and outdoor picnics. Lyme disease can be a difficult condition to diagnose. While the characteristic skin rash can provide an important clue, not everyone with Lyme disease may develop the rash. Oral antibiotics are recommended for the treatment of early stage Lyme disease. You can reduce the risk of infection by being aware of ticks and which areas they normally live in, wearing appropriate clothing in tick-infested areas like a long-sleeved shirt and trousers tucked into your socks, using insect repellents, inspecting your skin for ticks, particularly at the end of the day, including your head, neck, hairlines, and skin folds, which includes your armpits, groin, and waistband. Making sure that your children's head and neck areas, including scalps, are properly checked, checking that ticks are not brought into your home on your clothes, and checking that pets do not bring ticks into your home in their fur. If you find a tick on your skin or your child's skin, you should remove it by gently gripping it as close to the skin as possible, preferably using a fine-toothed tweezers, and pull steadily away from the skin. If you are worried that your child may be developing Lyme disease after a tick bite, you should go to your GP or go to your nearest emergency department to have your child seen.
So, food allergy affects approximately 3% of young children. That's roughly 1 in every 30 children, mostly young children. The commonest allergen amongst Irish children would be egg white, and most children are exposed to egg white in the form of scrambled eggs, which is partially cooked egg. The other allergens that are recognised would be milk, notably cow's milk, and then nuts, probably peanut and the tree nuts. Approximately 1% of children have peanut allergy. Typically, the reaction that parents will notice with a food allergy is a rash on the skin, which is usually a redness around the lips or the mouth, redness on the chin, redness around the eyes, or they may have a hive or nettle sting-like rash. They can also get swelling of the lips or swelling around the eyes. In some instances, food allergy reactions can be more severe, such as with coughing or wheezing or other airway difficulties. Children may also get vomiting and abdominal pain, and these would certainly be more severe type reactions, but are less common. The The majority of food allergic reactions in children are managed with an over-the-counter antihistamine, which is typically given by mouth. These have a prompt and immediate effect. In certain situations, such as those children with more significant reactions, they certainly may need to have an adrenaline pen as part of their allergy action plan. Majority of food allergies in children will resolve by late childhood, and this is certainly true for milk allergy and egg allergy. However, certain nut allergies will persist through to adulthood, and we are well aware of many patients with peanut and tree nut, which are almonds, Brazil nut, walnut, etc., persisting through to adulthood. If you have any concerns about your child having had a reaction to a foodstuff, you should contact your primary care provider. More information is available on the Irish Food Allergy Network for parents, and risk factors for more severe reactions would include severe or poorly controlled asthma. So certainly if your child has had a reaction to a foodstuff and also has a diagnosis of asthma, you should obtain further information and contact your primary care provider, and then ultimately secondary level care through an allergy clinic.
Vaccines are a simple, safe and effective way of protecting children from serious infectious diseases. Before vaccines were introduced, diseases like polio, measles, TB, diphtheria and whooping cough caused serious ongoing health conditions and killed hundreds of children. Today, because of vaccines, it is extremely rare to die from these diseases in Ireland. Vaccines work by triggering our immune system to fight certain diseases. If a vaccinated person comes in contact with these diseases, their immune system is able to respond more effectively, either by preventing disease or reducing its severity. Getting your child vaccinated helps protect others in your community, like your neighbour who has cancer and cannot get certain vaccines, or your friend's newborn baby who is too young to be fully immunised. When everyone in a community who can get vaccinated does get vaccinated, it prevents the spread of disease and can slow or stop an outbreak. Routine vaccines protect against 14 childhood diseases, including whooping cough, measles, German measles, meningitis and pneumonia. 2 vaccines also protect against cancer, the HPV vaccine and the hepatitis B vaccine. The recommended vaccine schedule is designed to protect infants and children early in life when they are most vulnerable. Their immune systems are not yet fully mature, making it easier for bacteria and viruses to multiply. Booster vaccines are given when children start primary and secondary school, as they are exposed to more children and therefore to more infections. Childhood immunisations are recommended at 2, 4 and 6 months, 12 and 13 months, 4 to 5 years and 12 to 13 years. These vaccines are available free of charge for all children. To be fully immunised, children need all doses of all vaccines in the recommended schedule. If your child doesn't receive the full number of doses, they're vulnerable to serious diseases. You can obtain the latest schedule information by talking to your doctor or online at immunisation.ie. Vaccines are very safe. However, like all medications, vaccines may have side effects. While your child may experience some discomfort or tenderness at the injection site, this is minor compared to the serious complications that can result from the diseases that these vaccines prevent. A slight reaction actually shows that the vaccine is having the desired effect on the immune system. A child may also get a mild temperature, be out of sorts and off his or her food as a result of the vaccine, but these generally get better themselves in a day or two with cuddling. Serious side effects from vaccines are very rare. If you have any concerns about vaccine safety, mention them to your doctor. Your child should not be vaccinated if they have a fever over 38.5 degrees. Check with your doctor if your child has ever had an allergic reaction or is undergoing treatment such as cancer treatment, which suppresses their immune system. Keep a record of your child's vaccinations. To find out more about immunisation, go to www.immunisation.ie.
Short stature is one of the commonest reasons for referral to a paediatric endocrinologist. Most children grow fastest in the first 2 years of life, so they grow between 30 and 35 centimetres. After that, then growth is relatively steady throughout childhood. So they grow at 4 to 7 centimetres per year until puberty, at which stage then they have a growth spurt in line with puberty. And girls usually have their puberty growth spurt early at the start of puberty, whereas boys have their growth spurt later on. Some babies who are born big at birth may cross centiles in the first 2 years of life in line with their genetic potential. When assessing a child for possible short stature, accurate height measurement is essential. And it's important that this is done by a fully trained nurse who has been trained in measuring height. We use a wall-mounted stadiometer to measure children in our paediatric clinics. It's also very important to know the parent's height in order to assess a child properly with short stature. Some children are small because they're from a small family, and therefore knowing the parent's height is very helpful. The most common causes of short stature are familial short stature, but other conditions such as constitutional delay of growth and puberty, in other words, the child is a late developer, may mean that the child is short now but will have a growth spurt later on. Although most children referred to the paediatric clinic with short stature are normal or normal for their family, if the child is not grown at a normal rate or has fallen off their centiles, they may need to be investigated further. The causes of short stature are broad and include genetic conditions, problems with the thyroid gland, celiac disease and deficiency in growth hormone, among other conditions.
Gastroesophageal reflux is called reflux for short. It is extremely common in all healthy infants where contents from the stomach backwash into the esophagus 30 or more times every day. Some of it will be vomited or spat out, but most slides back down into the stomach. The frequency of reflux declines as baby gets older and generally decreases towards the end of the first year of life and is unusual in children older than 18 months. In the majority of infants, a focused history and physical examination will confirm that the reflux is uncomplicated and little further evaluation or intervention is usually required. Simple measures will usually help control the symptoms, like positioning your baby upright after feeds for about 10 to 20 minutes as they get their wind up, elevating the head of the mattress in the bassinet or cot with a small rolled up towel underneath the mattress, or thickening the feeds with a thickener. Warning signals that may suggest symptoms of obstruction or disease in a refluxing infant include the following: the presence of green bile in the vomit, gastrointestinal bleeding, which is characterised by blood in the vomit or blood in the stools, consistently forceful vomiting after every feed, onset of vomiting after 6 months of life, abdominal tenderness, abdominal distension, recurrent pneumonias or chest infections, constipation and diarrhoea. Infants who have reflux and are not gaining the appropriate amount of weight for their age need to be seen by their GP or referred to a paediatrician for review. Reflux and poor weight gain also may be caused by food protein-induced gastrointestinal disease, and this is often referred to as cow's milk protein intolerance, because cow's milk protein is the most common trigger. All formula milk or non-breast milk is made up of cow's milk and will contain the cow's milk protein, whey and casein. Breastfeeding children can also develop cow's milk protein intolerance. For mothers who are breastfeeding, if they have a high dairy intake in their daily diet, some of the cow's milk protein will pass directly into their milk and subsequently into their child when feeding them. Symptoms may include the following: taking longer to feed, pulling off the breast or pulling off the bottle after soon starting a feed, crying associated with feeds, difficulty to burp and wind after feeding, lifting their legs a lot and passing a lot of wind, or being unsettled while they sleep. For most formula-fed infants with reflux and poor weight gain, which is thought to be due to cow's milk protein intolerance, we suggest a 2-week trial of an extensively hydrolyzed formula. For breastfeeding babies, we would advise the mums to remove all sources of beef and dairy from their diet and to replace with an equivalent substitute, ensuring they are getting sufficient amounts of calcium and vitamin D in their daily intake. Products that contain cow's milk protein or dairy products include such items like milk, cheese, yogurts, chocolate, ice cream and cream. The response to this change is often more delayed than in formula-fed infants because it takes some time to eliminate the offending protein from breast milk, and small amounts of milk or beef protein may be found in foods. If there is not a clear response to the diet change during the trial, other diagnoses and treatments should be explored. If you are concerned, please see your GP or paediatrician.
A key part of your child's development is their emotional well-being and mental health. This is just as important as their physical growth. All children will experience feelings and emotions that become overwhelming at times, and this is normal. Most children will overcome these difficulties with support, but sometimes, as a parent, you might become worried that your child is presenting with symptoms or with behaviours that concern you about their mental health. And this can be a really difficult time trying to figure out how to get help for your child. It's important to respond to these early signs or changes in your child's behaviour as soon as possible, as this will allow your family and your child to access help to move things forward. If you're worried about your child's mental health, the first step is to try to open up a conversation with them to understand what's going on. And this can be hard as a parent, but it's invaluable that your child knows that you're there for them at any point. And sometimes by doing this when driving in the car or when doing something together can be really much more successful, because children often open up more when they don't feel on the spot or that they have to make direct eye contact. It's also important to try to not ask too many questions at this point and just let them talk. And if it's too hard to talk, you could encourage your child just to write down how they feel. Young people worry about opening up. They worry that they won't be believed or that they won't be taken seriously when they tell their story. But if you listen without judgment or interruption, it can be a really helpful starting point for your child and really helps them to feel validated. For any parent or guardian, this isn't an easy conversation to have. Parents are often afraid to ask, "Are you okay?" as they worry that they won't be able to deal with the answer. And I think it's really important to know that there is help and support out there and you're not alone. In terms of accessing help, talking to your GP is the best place to start. Your GP will be familiar with the local services in your area and be able to support you in figuring out what is wrong and where to access the appropriate help. And sometimes if your child has a conversation with your GP, this can also help to start to resolve the difficulty. Regardless of the level of severity of your child's mental health needs, the most important thing which you can do as a parent is to let your child know that you're there. And with the right level of support and treatment, young people can overcome their mental health difficulties and really learn lifelong skills and build their resilience. So with help and support, it doesn't have to feel as overwhelming as it might do at the start of this journey.
It is likely that nearly all children will need to take medicine at some point during childhood, and we know from talking to parents that this can be a worry at times. As well as providing you with the medicine your child may need, your local pharmacist is always available to help with any queries or concerns you may have in relation to your child's health. If you find it difficult to read and understand prescriptions or instructions, don't be afraid to ask us for help. Your pharmacist can easily explain them to you. Every pharmacy has a private consultation room, which you are more than welcome to use if you would feel more comfortable speaking in private. It is so important that you read the instructions carefully. No matter how well you think you know your child's medicine, check what it is for, and how to use it. It can be a good idea to keep a log to record doses given. This can help when multiple people are giving your child medicine throughout the day. It is important to use a correct measuring device, for example an oral syringe or measuring cup or spoon, to ensure you are giving an accurate dose to your child. Avoid teaspoons as these can vary widely. Remember, when medicine is not taken properly, it can cause more harm than good. And for this reason, we always need to ensure that we keep medicines out of reach and sight of children. Some medicines may need to be stored in the fridge and out of direct sunlight. Again, make sure your little one won't be able to get to the medicines themselves. Read the storage instructions or ask your pharmacist if you are unsure. Also, if you need to take medicines yourself, don't take them in front of children as they often copy what they see adults doing. Medicines can interact with other medicines, vitamins and even food, so make sure you let your doctor or pharmacist know if your child is taking any other medicines. This will help you to use the medicine safely and will help avoid taking things that don't mix well together. Do not use any medicine past its expiry date as it may not work as well and may be harmful. Don't destroy or throw out unused or out-of-date medicines yourself. Return them to your pharmacist who can destroy them safely. Please feel free to visit your local pharmacist for further advice and support. We are here to help.